Yeah, thanks very much, Damien. Thanks for inviting us to be part of this webinar series. We've been given this topic to talk about around models of care, and we've added our own little byline there as something of a disclaimer, really, that actually this is not at all the topic that we can talk on. We don't know what the successful models of care are for Indigenous people. I don't think anybody does at the moment. We're not even really sure we can talk about what well-established models of care there are for young people with diabetes in primary health care. So what we're going to be talking about today is just what we've been trying at Worley, and we hope it's the beginning of a bigger conversation. So we're going to tell you a bit about our journey so far. So a few years ago, I guess we started to become aware of youth type 2 diabetes as an emerging problem, and we recognised that it was starting to grow very quickly, even within our own service. At Worley, we have an acute care clinic, we have an adult chronic disease clinic, and we have the women's and children's clinic. For youth type 2 diabetes, we felt that it didn't fit neatly into any of these clinics at Worley, and so we were starting to think about how we might need to adapt our existing health service to try to allow and to accommodate and to actually really embrace and try and work with young people with their diabetes. Whoops. Sorry, that's not supposed to happen. I might just flick back through. Yeah, a quick little preview of what's coming. So I'm just going to give a little bit of an overview of our journey so far, and then Jamie and Cheryl will just talk through a few of the more specific things that we're doing. So I guess when we started to think about young people with diabetes, we thought about some of the challenges that we were facing. And the first of those was, how are we going to be screening our population for youth diabetes? We had a few debates about what we needed to address and how to do it. We looked at the idea of being opportunistic in our screening. So that is, wait till young people come into the clinic and screen them on every occasion, that allowed, versus being more systematic and trying to take our screening into schools. We looked at the ideas of targeted screening. So this would be based on, individual risk assessment, which we sort of have some guidelines for, versus broader population screening, which had some advantages for us. And we looked at how we were going to try and incorporate HbA1c versus what we'd done previously over the last 10 or 15 years, which was just a random BGL as part of normal care. So what we currently are doing is most of our screening takes place through our school screening program, and we were lucky that we had an existing school screening program, which we just modified to include HbA1c instead of the random BGL. We've got a portable HbA1c machine that we use, and our aim is to be able to offer annual HbA1c from 8 years in the higher risk groups. So we still encourage opportunistic screening through the clinic, and we still try to make sure that we're recording a risk assessment on individual children, young people's charts. But for us, the move to be kind of broader and apply almost population level screening was really just a very pragmatic one, that when we're in a school situation and we've got, we're screening 30 or 40 children in a day, it's not possible to do that individual risk assessment in the moment. We're also trying to make sure that we record waist height, circumference and acanthosis through our normal, through our school screening, but also through our normal health checks that occur. As with all the other screening that we do, we find that sometimes the biggest challenge of screening is following up. So we have had children identified who are at risk of diabetes or even have diabetes that we've then had a real challenge to try and follow up through the clinic. Do we think our screening is working at the moment? I guess we sort of have mixed feelings about it. This shows the last 12 months and how many of our regular clients have had a HbA1c recorded in these age groups. So you can see it's really very low in the middle upper primary years. It's probably a little better in the high school years, but at 17, 25% of that age group have been screened So there's still, I guess, a long way to go, and it sort of reminds us that we probably need to be looking at multiple methods of accessing these young people and being able to screen them. There's a lot that won't be at school or won't be at school on the days that we're offering screening. And I guess in those later high school years, the numbers probably drop off a bit as well. So we think it's definitely helping. These numbers are probably better than we've seen previously, but there's probably still other things we need to add in there. This is just an example of the letter that is sent home after our school screening to families. It does have a lot of the, raw data, I guess, from the school screening check on the other side of the form, but we try to include this as just a really simple traffic light system that tries to give family the information about whether there's a risk of diabetes or not, and that we just tick these boxes. And at risk of diabetes, we might also include in that, people who have a high BMI or have where acanthosis has been noted at school screening, so not necessarily just based on HbA1c. I guess the next challenge we've thought a lot about is education and engagement, both of young people but also of the people around them, so their family and the broader community, but in particular schools, I guess we've put some effort into. So I think we recognise that at a broad community level, understanding of type 2 diabetes in very young people is new, and it's not particularly well understood, and there's definitely some stigma around it, particularly around the idea that it is more of an adult chronic disease condition. So we've addressed this particular challenge with a couple of different things. One is a peer support group for young people with diabetes, and Jamie will talk a little bit more about that in a few slides. And we also try to provide some education for the support staff in schools who are helping young people to manage their diabetes. That's often administrative staff or other sort of key people within the schools. Then the next challenge that we've thought about is around management, and this is probably one that consumes us more than anything. Management of diabetes in young people is really difficult. As we've talked about a lot through the webinar series, the social barriers to lifestyle change, there's lots of social barriers. I think young people in particular often lack the resources, capacity, autonomy to make changes in their own lives themselves. There's a lot of barriers around the management of medication, and we see this from the very beginning of picking up medications, understanding or literacy around medications or dialing up insulin or understanding BGL sometimes, to the storage of medication, to actually taking medication, swallowing tablets, and really keeping routines and remembering and making sure they're there on holidays and all those sorts of things. And I guess the other thing is that we recognise that there's a real challenge around engaging young people to come into the clinic setting to have their health checkups and to seek care. We really recognise that the current models that we work in don't fit very well. Young people feel too big for our kids' clinic, and they feel out of place in the adult chronic disease world as well. So in order to address some of these challenges, we set up a dedicated type 2 diabetes clinic for young people. That happens in the physical space of our women's and kids clinic, but we've dedicated a time when hopefully it's mainly just young people with diabetes around, so they've got that kind of peer support and don't feel so out of place. And Jamie will talk a little bit about the ups and downs of that. We try again, I guess we're just trying to push the boundaries of what our existing health system looks like to try and stretch to reach these people a little bit more. So that sometimes means going to young people, so outreach, home visits, and we try to do that on a fairly scheduled basis, once a fortnight, just to check in to see if they've got medications, if there's what's going on at home, and what's happening at school. We do a lot of school-based engagement, so that's basically using the schools as a resource and as an existing support for young people, and trying to make sure that the education, is carried through from home to school. And we've also worked on developing our own care plans, so that when young people do come into the clinic, that their experiences of being in the clinic is just hopefully a little bit more relevant and a little bit more useful, and they feel a little bit more okay about being in the clinic with us. And the final challenge that we've thought about, as in sort of this overview of how we're managing, is looking at the systems. We recognise that there are really big gaps in our existing systems in wanting them to be able to deal with young people with diabetes. So we think there's a lack of clinical knowledge amongst staff. Most of our staff are very, very used to looking after adults with diabetes, but I think there's still some limited understanding about how early we're seeing type 2 diabetes in young people, about the need to screen for it, the differences in medication management, the differences in all those social barriers that we talked about, and also just differences in the progression of the disease. Within our Communicare system, or our templates that we use, they're often not fit for purpose. So some of our templates include a mini mental examination or other things that just are adult focused and not necessarily what we need to be recording or tracking for young people. There's a lack of educational resources to use within consults to help with understanding around what diabetes is, and how the management, around management. Some of our support services, which might be available to help adults with chronic disease, are often not focused at young people, and often just not available to them. So, a 15 or 16-year-old may not be able to access things like Centrelink, or some of our support services that help with medications, food security, all those sorts of things. So very reliant on families to be able to access those services. And I guess also that the funding models can be rigid. So we know that most of our funding, we need to be able to provide in-clinic billable items in order to gain the usual funding associated with chronic disease care. So we need to be doing GP management plans in clinic and health checks and that sort of thing. So, and this doesn't always fit with a group of people that don't really like to come into the clinic for those things. So what are we doing in this space? So as I said, we're developing a care plan and also a school care plan. And I guess that's just trying to push the boundaries a little bit of our systems to make them just more youth focused, and same way also making changes to Communicare where we can. We've been working for a little while now with Menzies on the referral pathway program, but also on their resource development, which hopefully into the future is going to provide a lot more resources that we can be using in this space. I'll hand over to Jamie at that point.
So just carrying on from Michelle's just identified all the issues or some of the issues that we came up with. I'm just going to go through how what we've come up with to work around them. So the first thing we did was try to basically come up with a youth type 2 diabetes specific clinic. So once a month we would try to run a clinic where they could come, and it would only be with other kids with diabetes. It was just to give a space that mixed chronic disease and kids clinic, because as Michelle said, they're sort of too young to fit into the chronic disease clinic, but too old to fit into the kids clinic. One of the other benefits was that it gave us a designated time to follow up care. So obviously we all run different programs and are managing different areas of health, and this sort of gave us a designated time to follow up and identify the issues. And also it meant that if you were, if they presented on a kids' day, you could be seeing kids for all different reasons, and then diabetes in the middle, and then another kid. So this was a way of getting around that. It hasn't been hugely successful, and it has morphed more into outreach, but we still try to get them into the clinic as needed. we need to work on how we evolve it better. So the reason it didn't work as well as we'd hoped was it was incredibly staff intensive. So we needed an allocated time, we needed staff to stay and work just that, not do other clinical areas. And so it just, we just often didn't have the staff available. And also the timing. So it needs to be after school, but that's not always practical with our clinic hours. So even if we worked a little bit later, like with transport and, getting the kids here and then getting them home, it just didn't really fit in as well as we'd like, which is why it ended up sort of morphing into the outreach and what we offer. Trying to follow them up, still trying to get them into the clinic, but seeing them at least at home and then trying to get them in when we can. This is the care plan we developed, which Cheryl's going to talk about.
So we use this instead of we use this instead of the adult care plans we have. Easier to interact when not on a screen. Wait for young people to make decisions and say what works for them and what doesn't. Encourages them to take control of some of their diabetes management.
One of the things I liked about it is we've found that the kids, well, everybody, but kids in particular, respond to like colours. So having the coloured HbA1c chart and being able to show them where their HbA1c is and where it was or how it's changed, like that seemed to work really well. So this ties into then one of the other things we started to develop was utilising the schools as a way to help engage the clients or manage the clients. So we would hope that apart from home, school is where they are the most. It's a stable or consistent environment. So some of the benefits of this are, they spend more time at school than anywhere else. It's stable. One of the other things I really like is that it adds more people into their support crew, I guess. So there's more adults that are involved in their care that they know that they can turn to. Food is often provided in schools, so that was a big issue with medication management, is that quite often food's not available at home, so no one's going to take their tablets if they don't have anything to eat. And as I said, getting the staff involved and becoming people involved in the care, so they can support education. A lot of the assisted learning schools will do, the teachers will get involved and use the diabetes as an education thing. For the more mainstream schools, it tends to be more medication administration and support and monitoring, but that is more than we get in other places. So we're really happy with that. And one of the biggest benefits is it's the most consistent compliance record that we have. So no matter how hard we try, we cannot get kids to bring back a record of their BGLs at home, or, if we ask them if they take their tablets, they say, yes, they are, but they might not be. Whereas at the school, we get a record of if they've had their tablets and what their BGLs are. So at least we're getting something as a bit of a guide. There's a lot of challenges which involve, so the level of support will vary from school to school. Some have the capacity to do a lot more, some don't. The attendance can be an issue. So even if the kids attend every day of every term, there's still 12 weeks of the year that they're not going to be at school, but often the attendance is erratic. It also means that there's a lot less family involvement than we would like, because we tend to deal with the school. We get the family involved with, starting the process, but then as it goes on, there's not so much involvement then. And also the food provided is not always optimal for diabetes. So while they are getting food, and that's a big plus, it's not always diabetes appropriate, and it's not really fair to segregate the kids out and get them to have different foods to everybody else. They're already feeling a bit different and segregated. So we try to do a bit of education on what food can be provided, but the reality is it's just what the school has and what works for them. This is an example of we came up with a school action plan at the request of some of the schools. So it's a template that we just fill in for the students, goes through, do they have their medications at school, what kind of medications, do they need help to do it, what, you know, like emergency contacts, what to do if their BGLs are really low or if they're really high. And the other picture is the record sheet that I give to the schools and try to get them to fill out and send back to me, just so that we have some sort of record of any BGLs or whether medication's been given or not. Yeah. So the one of the other things that we do is we came up with this idea of offering a peer support group. So it's non-clinical. We run it once a month if we can, and it's all about we take them fishing, or you know, we've got a youth shared space where we can play games, do art and craft. We've often kicked around a footy, stuff like that. The biggest benefit for us is the relationship building. So for the kids with each other, and also with us, like it's a consistent interaction with us, so they're used to us and know who we are and are happy to talk to us. It really helps with the reducing the stigma, so they know that there's other kids out there with diabetes and that they're not alone, I guess. So even if these are kids that they wouldn't normally associate with, they know that there's someone else out there with diabetes too. We also do a lot of education through modelling. So instead of sitting there and talking to them and lecturing them, we try to make it as interactive as possible. And, you know, we make food and get them making food. So we talk about what the food is and how it affects their diabetes, do things like taking their blood sugar before we do some exercise and then kicking the footy around and taking it again, just to see if that helps. It's different every time. But yeah, we usually get some sort of indirect education through what we do. There's a couple of challenges. So it's been a really slow progression, number one. We've been doing it for almost 2 years and we've probably only had 12 or 13 sessions. And we don't get the entire cohort of kids with diabetes, but the ones that we do get have been coming consistently, and they engage with the clinics way more than they would have previously. It's really resource intensive, so it takes a lot of planning, a lot of logistical organisation, and then staffing as well. So we need a sort of minimum of 4 staff. We like to have at least 2 male staff, which doesn't always work. Yeah, it's often seen as non-critical, so the clinical workload will take over, and that's where we struggle with the staff. So it's a big call to pull 4 clinicians out of a clinic that's already understaffed. So if things are busy, we don't tend to get it off the ground that month. There's a big age range of kids. So I've noticed that they seem to sort of separate into the younger kids and the older kids, and they all have different needs and they want different things out of it. But we did have discussions about having a male and a female group, but it just, again, logistically was not possible. And it's also been pretty unsuccessful at engaging families, because we initially tried to get the parents to come along as well, so we could get some family involvement, but again, it just was not really possible. And yeah, it was just too hard to get everybody there. And one of the biggest challenges is that, how do you measure success? So we're not seeing the biometric improvements that we would normally use to measure something, and it doesn't really translate to the same level of clinical engagement, as in if they come to the group consistently, they still might not come to the clinic consistently, but it keeps us on their radar, and they know that when we go chasing them up, they'll still talk to us. Or if we say, you know, the group's next week, but you've got to come to the clinic beforehand, then they're more likely to do that. But the biggest success for all of us is the connections. So these are kids that didn't know our names, and, you know, it was all really awkward and didn't really want to interact with us. But then, you know, they now know us. They ask for us by name. They ask for meds if they don't have any. So it's a really it's been really successful for us in that, and that's far more important, we think, than getting the HbA1c under control. Here's some photos of things that we've done. So, like I said, we've taken out fishing, kicking the footy, playing games, all that sort of stuff. So it's we enjoy it. This was an example of at the last group we did. Just at the end of it, we did about a 10-minute discussion about what they would tell someone who had diabetes, newly diagnosed with diabetes. And initially it started off as telling us what we wanted to hear or what they thought we wanted to hear, but then it did get into how they felt, and it wasn't always good. Like, they were happy to tell us when they were angry or unhappy about it. And that, to me, that's one of the biggest pluses, is that we're a safe space and they can be honest and tell us how they really feel and what they are feeling about their diabetes, which we never had that sort of connection before. So then, even though we've established these, or tried to implement these models and come up with different ways of doing things, they don't always fit, and we really need to work them individually. So this is an example of one of our kids. We tried to get her on some metformin, but she just wasn't able to swallow it. It didn't work. Insulin was not practical, and she had no place to store it safely at home. So then we ended up just putting her on once a week Ozempic. And we do try to get her into the clinic, which happens probably 50% of the time, but most of the time it's a home visit. We get her into the back of the car, she has a chat to us, takes her BGL, injects, and then has a bit of a chat, and then off we go. She's probably one of our biggest success stories, in that the youth group has probably been the best thing at getting her to engage. So she really enjoys it. She likes coming along. She chats to the other kids her age. But more importantly, she's learnt to access care. So there was a time where her mum rang me to chase up some domestic violence stuff that she needed help with this kid. And also she was really unwell one day and needed to see a doctor, and she tracked down Dr. Michelle in a closed clinic just because she knew that we would help. So we think that all of these things we've adjusted what we do to fit around her and what works for her, and that's helped her engage with us. This is her HbA1c profile. So you can see, like, she was diagnosed and we were having all the issues with medications and not getting it under control, and then so it shot up, and then we got her onto the Ozempic, and it came down, but that dropped towards the end of last year. So COVID shut down our services, and we were just not able to offer her the support that she needed, and so her HbA1c went up again. But now that we're sort of back on track and getting her in most weeks, it's come back under control. But as you can see, it's definitely a roller coaster. And so this is another one of our kids. So he does have his meds at home sometimes. He tries to, but the realities of home life mean he probably doesn't have them all the time. If he attends school, he will have them there, and the school's really supportive of getting him medications and keeping him his diabetes under control. But he's had lots of family upheaval. So his mum had to, and his dad had to go to Adelaide for a renal transplant, and they were away for about 8 months. And then that just sort of translated to his HbA1c being a big roller coaster. So when it went up really high again, that's when his mum was away. And then when she was able to come back to Catherine and be back at home, it sort of got under control again. But then she's had some more complications and ended up being away again. So it's really hard to manage his diabetes when his family life can be really chaotic. But in spite of all of that, when we did his last care plan with him, he told us that he was really happy with his diabetes control, or his diabetes management. So that's one of the benefits of the care plan, is that it shows us what we think about their diabetes is often not what they think about their diabetes. So as we say, it's all about riding the roller coaster, and changes in their social circumstances will impact them more than other people, more than adults. They don't have a lot of control over what goes on in their life. And so because of that, we need to be able to be dynamic and flexible and scale up any support that they need. Even if we wouldn't have done that for the adult clients, it's what we need to do with them. And a lot of the issues that we have, or the challenges we face, are non-clinical. So housing and social support and things like that, which we don't normally, we're not really able to fix those things food security, all of that stuff comes under areas that are not ours, but we've tried to work around them. So one of our kids, we provided a locked box for her to keep her medication in at home, and we supplied some non-perishable food to help her with swallowing the metformin tablets, because that's her biggest issues. But a lot of it is just working around the family upheaval. So, and that's where the outreach came in. So, we couldn't get them into the clinic, but then they still needed to be seen, and we needed to know where they were at. So even if we just go to their house and have a bit of a chat and do some BGLs, like that can sometimes be the best that we can do in that moment. It's not always it's not practical to get them in the clinic for their care. So moving forward, where do we go? We need to build capacity now. So we know that bigger waves are coming and that this is only going to get worse. We need to build our team. Like we need to have both clinical and non-clinical people on board. So community liaison is a huge thing, getting someone involved that we can get out in the community with and that will help. Getting the kids that have already come through these programs, getting them to feed back in as mentors, I think will be really helpful in the future. And also Worley has a community services department, which we're really trying to get them on board as well and help with these kids and help with the social things that we can't. Education is really big. So we need to not only educate the staff who it is, the clinical, this is escalating faster than most of the clinical staff are aware of. So we need to improve their clinical understanding of what's going on, but also the community, because this has become a massive community issue that without their support and change, like we're going to struggle to keep up. So the community-led change is really important. So education all round. And then continuing to work on our systems development. So we know that it's going to get bigger and get more intensive. So making sure that we're able to scale up our service delivery as needed, so these kids don't fall through the cracks. Basically, we need to be ready to face the onslaught and make sure that we have the capacity to handle that. Funding. So we need to look at some funding model changes, how we're going to do this, and prevention, which would be lovely. I think the next webinar series is on prevention, so hopefully they can give you all the answers that we don't have. If anyone has any questions, or if does anyone have any answers, because we don't have them all.
Thanks, guys, for presentation. So I welcome our participants to type their questions in the Q&A box and then vote on the questions that they'd most like to have answered. I'll start with a question. So it's amazing what you've been able to do in the time frame that you've had at Worley. I appreciate that that's probably taken a couple of years. If we've got some people who are on the line from different places in Australia and they might just be starting out with noticing that there's a population of young people with type 2 diabetes in their local area, where would you recommend that they start?
I guess work out what your service has the capacity to do, and build on that. Yeah.
And I think mapping your existing service and trying to overlay, look at where the gaps are. We recognise it's going to be very different from one organisation to another, even within the territory, even within our local area, it's going to be quite different depending on what the service already has. But I think in terms of, I think we feel like our peer support group is only just starting to show some benefits, and hopefully those benefits will be amplified into the future. So, even though it's a really hard thing to do straight up and probably doesn't seem like the highest priority, I think getting something like that going early on is a really important thing.
Yeah, that's the thing that's helped us engage them the most. Mm-hmm. Yeah.
Okay, I've got a couple of questions coming through. First one here is, what is Communicare?
Because but we got the Communicare system here.
Mm-hmm.
That's our medical record that we use. Yeah, so it very much is based around sort of population health and templates which guide management. So it's really important that those templates guide management the right way, because we have a range of staff using them of different levels of experience. So the more the templates work to guide staff to be comprehensive and appropriate, then the better it works. And it's also good for exporting data and being able to track a lot of changes and things like that. Okay, I've got another question here. Can we please have a digital copy of your coloured care plan?
That's we often get asked, and yeah, I guess.
But yeah, it probably comes with the caveat that it's really very draft form, and we're really happy to just have people develop it. And I think we've talked about that a little bit through the Menzies group, at looking at more people using it and then looking at a way to develop it and you know, maybe even validate it a bit. But it really was something that we threw together and we're just using. But yeah, absolutely happy to share. Sure, no problem. Perhaps if people are interested, they could email myself or the Youth Type 2 Diabetes email that they get emails about the webinar series on, and then we can put you in touch. Okay, a clinical question here. So, do you diagnose pre-diabetes too? If so, what is the HbA1c range for pre-diabetes? We've also got Angela here as well.
Could we use the...
Yeah.
Maybe Angela could answer
that. Did you want to answer that, Angela?
Sure.
Hello, can you hear me? We don't actually use the term pre-diabetes in children. It's a term, and there's no definition as such in children, but we would consider a borderline HbA1c of being 5.7 to 6.4%, and those children should have further workup, including an oral glucose tolerance test. But we don't actually use the kind of terminology or definition of pre-diabetes in children or adolescents.
I ask Angela as a follow-up, would you still identify those young people who fall within that HbA1c range as at risk of progressing to diabetes and suggest further interventions for them?
Yeah, so in the screening pathway, they would all be considered at risk. And so they should, if possible, have an oral glucose tolerance test, because a OGTT determines slightly different. You might find someone that has a borderline HbA1c but has diabetes using an oral glucose tolerance test, or you might find impaired glucose tolerance, for instance, and that kind of gives you really an idea of how they might progress and their prognosis over the next 12 months. So if someone had an impaired glucose tolerance test, they're particularly high risk and are very likely to progress to diabetes within kind of in the near future. Or if someone had a normal oral glucose tolerance test and a borderline HbA1c, they're probably less likely to progress in the near future, that they might progress over a long time. If you're unable to do an oral glucose tolerance test, and acknowledging the difficulties of kind of getting that done, particularly remote, would suggest that you do repeat HbA1c in 6 months' time and kind of keep doing 6 monthly HbA1cs on those young people, and also explore their comorbidities, such as do they have high cholesterol, what's their blood pressure like, what's their sleep like, what's their mental health like, what's their renal function, kind of looking at all the other aspects of their health.
Excellent, thank you. Another question here. So, with school engagement, are you educating peers as well to help with bullying due to lack of understanding? Question mark. Sorry if I missed that.
Not really. We've just been focusing on what diabetes means, what it is, what it means for the kid. I guess that's probably more up to the teachers. They're in that setting all the time to be able to identify any issues on that regard. Yeah, we haven't done any of that sort of stuff. It's just been how to manage their diabetes at school.
Okay, thank you. Another question.
Damien, sorry, could I just jump in to add that that's an issue that's come up in the co-design work for the Youth Diabetes Project from young people affected by diabetes, have kind of articulated the need for schools to have more information so that they reduce bullying, but actually often they've said to reduce the questions that they get from teachers and to kind of for the teachers to have a better understanding. So that is something that is kind of will be a focus of the project, and thinking about how we can improve information that's provided to schools to kind of reduce the stigma and kind of reduce the questions or bullying that gets directed to young people.
Yeah, thank you. So another question here is, I found the support group discussion interesting. Do you have any other questions that you asked during this peer support group?
We've done a couple of different activities. Early on, we did a couple of more structured activities around connection. So trying to map, I guess, young people's support groups, or see how they identify their support groups and potentially how to expand those. We have a lot of, it is very unstructured. So we spend a lot of time sitting, playing games or doing art and craft and having just general chats. But interestingly, this last one we showed you that information that in response to that question, we'd actually backed off doing anything structured for a while because there was a real reluctance for people to join in, and it kind of increased the awkwardness of the group. But what we were really surprised about this time round was we left it right to the last minute, actually, really until we're ready to go. And then this time round, everybody was really wanting to engage, wanting to talk. The conversation very quickly became, really engaging and really quite, almost heated in some ways as people were talking about when they first were diagnosed and how angry they felt and things like that. So I guess when we left after our last group, we sort of recognised that there has been a shift in what the young people are comfortable with. And we probably had to go through that period of really just scaling it down, not being too structured, not putting anybody on the spot or expecting too much of them, and just really, really building the relationship. But we have probably got to a point with that particular group that really now they're almost looking for more, and they're looking for that chance to, whether it's to vent or to discuss or to, try and, just relate, I guess, to each other, but in a more structured way. So I guess it's something that we'll be thinking more about, what are the other little areas that we want to tap into. But one of the things that came up a little bit was around mental health. So that feeling of, it can be really emotional to have diabetes, and, is diabetes going to be with us for life and that sort of thing. So I guess we'd be looking at, maybe exploring some more ideas around, that link between mental health and diabetes, how people are coping.
And also, like, initially everyone was just really awkward and uncomfortable and didn't really want to get involved. So we did try, like Michelle said, we tried initially to do some stuff and it just didn't work. So we just sort of went back to trying to do it indirectly. And I mean, we would be quite intimidating, I guess, to a group of kids that we've brought them all to this place and said, come hang out with us. But one of the things I found really fun was, like, with the fishing and the football, they were teaching me. So I don't know how to tie a fishing knot. They would sit there and show me what to do, or we'd be laughing about how bad I am at kicking a footy. So that sort of brought me down to their level a bit. And it's from then, it's like as the relationships have developed that we're getting more interactive discussions with them. So it's just in the future, like what we do moving forward, I guess, will be that sort of stuff.
Yeah, thank you. It seems like something that requires a lot of groundwork and building trust and relationships first.
Yeah.
A comment here, a couple of comments actually. Great work, Worley, especially in these times of workforce shortages and I presume no funding as well. Thank you and great. Which I guess leads me to a question. Obviously, this has taken a fair bit of work on your side to be able to establish what you have. Who did you need to gain support from internally to be able to do this?
I think we did a little bit of let's just do it, see what happens. But initially, when we planned it, we had the health promotion coordinator. We had one then. She did a lot of the proposal work and sort of put it together, and then I think she did a lot more of that sort of background stuff. Who did we take it to?
Yeah,
The senior manager.
To the senior manager. Yeah. I mean, I think we have tried pretty much to work within what we have, so we haven't had any additional funding. There's a bit of additional after hours that gets paid and that sort of thing, but I think it is definitely one of the challenges that we face, because really to make it sustainable and to be sure that it continues into the future and even expand, there probably does need to be a real commitment and some dedicated funding to achieve that.
And to follow up on that, what might you do to make a compelling business case to show that this is something that health services should be investing in and funding?
Yeah, it's really hard. You're talking to the clinicians. I mean, I think we see it, don't we? We see that this is it is going to be the only way that we can engage this group, is to be flexible. So I think in the longer term, we're going to, our business case might develop out of some changes in our data and our KPIs. But I do think that's a little way down the track, and it's probably a little bit of a leap of faith for all of us to be trying to figure out how we tweak the systems we have to make them work better, while we don't have good understandings, we don't have good comparative programs elsewhere, or similar things that are being run, or just research to back us. So it is a bit of a leap of faith, and I guess we've tried to not overextend ourselves so that we're not causing too much grief for management when we don't have that data. We don't have we can't ask too much, but I think over time we'll be able to develop more evidence that it is what we need to go forward.
And I think that ties into the clinical staff training, is that, as we said, this is escalating faster than anyone has realised or can keep up with. So if we can get the general clinical and management population to understand what the realities are, then we might be able to direct some attention our way.
Another question here. Forgive my ignorance. Do these young people have any access to any formal or informal mental health support services at the moment? Do you find a high rate of depressive symptoms? Sorry if I missed this at the start.
Yeah, I think, it's definitely, it's hard to tell. Is it diabetes related, or is it just life in general related? I think this is it's just another layer into what is already a complex social issue. Catherine doesn't have an amazing selection of mental health services. There are a lot that are youth targeted, but whether or not these kids have the capacity to access them is probably more the issue.
Yeah, we don't see them accessing them probably as much as we feel like it would be beneficial for them to access. But we do have Headspace, and we have our own community services program with counsellors and psychologists. I guess for us, one of the things we would like to really include in our peer support group, we did try from the very beginning, was to include someone from our wellbeing unit or mental health, because fundamentally that's a really, really big part of what we're trying to address, is the difficulties, the emotional and the mental health drain of dealing with this chronic disease on top of everything else.
And can I ask, with your youth support group, anecdotally, have you noticed any qualitative changes with the young people who have attended that versus the people you might see who don't?
Absolutely. The ones that come are happy to see us. They might not be happy about their diabetes, but they're much more engaged with how to manage it and how to just how to deal with it. The ones that don't come to the group, we hit a lot of walls every time we try to see them.
Yeah, it is really noticeable. And I mean, there'd be young people that Angela remembers from very early on who wouldn't say a word in a consult, but now, they're very ready to fill us in on everything, very articulate. So I think we see that. Yeah, definitely.
That's excellent. Have you got enough numbers or the data to show any, clinical differences between the groups that I guess do come to the peer support group versus those who don't?
I would say that the kids that don't go, their HbA1c record's not a roller coaster. It's a straight line where it shouldn't be.
Having said that though, so some of the young people that don't engage in our youth group are from far more stable family backgrounds or in territory family care often. So we do find that some of the young people that are coming to the peer support group really regularly are probably some of our most poorly resourced and unstable home environments, and they're probably the ones that are looking for something more than the others. So definitely I can think of a few young people who are not involved in the peer support group at all, but are managing their diabetes really well with really good family support, and they probably don't have the need for it that the others do. But no, we don't have the numbers for the data or the longevity probably, or yeah.
No problem. No, that's a really good point, isn't it? That might not actually be a fair comparison between the two groups. It might actually be that those young people, like you said, who attend the group are actually quite different and maybe need the extra support, and having it there for them is incredible.
And I think ultimately probably what a lot of those young people are looking for is additional social support, whether it's around diabetes or anything else. I'm not sure, but it's just additional support.
I've got one more question. Sorry, Angela, did you want to mention something?
I just wanted to comment that one of the things that I think the Worley team do so amazingly well is their level of care that is really apparent. And I think young people really respond to that because they know there's a stable team who care about them and care about them as a person, not just their diabetes. And so I think that really is infused in everything that the Worley team do. And yeah, I definitely see a change in young people over the last few years in how their engagement or wanting to talk, or just kind of general, and these really high risk young people that may have been disengaged from school for several years, have trauma histories, domestic violence, food insecurity, and it's a really complicated past. And it just kind of really shows the benefit of a stable health team who care about them and respect them as people. And I think that's something for us all to learn from.
Thanks, Angela, very much. One other thing we didn't mention, but was a few years ago, Angela started running her endocrinology clinics here at Worley too. And for us, embedding specialist clinics into primary healthcare has been a really successful model. So it's just another barrier that's reduced because young people are coming to the same place that they know, and they know that Angela is, part of our team and embedded in that team. And in fact, they were saying the other day, they were asking when you're coming again, Angela, and they wanted to know if you're bringing your kids. So that, it's really nice to have that kind of continuity of care that extends to the specialist level as well.
Excellent. I'm mindful of time. If there's any last questions, I'd welcome our audience to type them in. I might ask quickly, I thought it was amazing what you're able to do with the school. And can I ask, how did that relationship form?
A lot of kids get medication through school anyway. That's not an unusual setup for us. So it just sort of started with, if that's something that we can tap into, then we would like to do that. I think there was one kid originally that we started the process with, and then thought maybe we could expand this out. One of the things that I found really fascinating, and from a non-clinical point of view, was, so, we want the kids to go to school because that seems to be the most consistent support they get for taking their medications. And one of the girls wasn't going to school, so I asked her why at the youth group, actually, why are you not going to school? And she said her shoes she'd lost her shoes, and she was getting in trouble if she didn't have those shoes when she went to school. So we just spoke to the Indigenous support worker at the school, and they worked around that, so she was able to then go to school and access her medication. So like I said, a lot of the challenges are not actual clinical issues, but where the conduit, I guess, between the having the good relationships with the schools has helped fix other parts of their, help support other parts of their care as well.